Hey guys, this is Dr. Shivam and let us start with another clinical shorts series via which we are discussing some of the very relevant clinical questions. So as your NEET PG is clinical based, it is wise to discuss these important clinical scenarios which are common and really important for you to know. So let us see our first question. A 19-year-old woman presented with a 3-day history of sore throat, fever, and dysphagia. On further examination, it was noted that she was having muffled voice, marked trismus, and drooling. The right tonsil was displaced medially and there is some swelling and induration at the angle of mouth. Now, as these features were suggesting of something very suspicious, we did a contrast enhanced computed tomography, that means a CT scan, and the picture has been given to you. Now, the thing that you can appreciate here is you can appreciate a hypodense lesion here, and what you can say is it is a collection, that means some collection and a bulge in the oropharynx you can observe from the CT scan. This is your mandible, the white things are mandible, your vertebra, your prevertebral space, right, your retropharyngeal space, and this space is your parapharyngeal space. Now let us see what questions your examiner wants you to know. What is the most likely diagnosis, most likely sources of infection, complication, boundaries, and how you are going to manage. So your examiner can frame any question based upon all these questions. So let us see what is our most likely diagnosis. So as from the CT scan and the clinical symptomology we saw, we can come to the diagnosis of parapharyngeal abscess. Seeing the clinical picture, the history, the examination finding, all are very typical for the diagnosis of parapharyngeal abscess, including the CT finding. Now, the typical infection sources are from tonsil, pharynx, nasopharynx, parotid, or teeth. So, any infection from these area, it can enter into the parapharyngeal space and cause parapharyngeal abscess. Now, why it is dangerous? What complication can happen? So, patient might present to you with airway obstruction due to increasing size of the abscess. That parapharyngeal space infection can spread to the other deep neck spaces like retropharyngeal space, carotid space, and to the mediastinum. It can cause cranial nerve palsies like 9, 10, 11, 12, so mostly 9 to 11, thrombophlebitis of IJV, and very dangerous, that is carotid blowouts. So dangerous but rare. Now, just to have an idea of the parapharyngeal space, you should know its boundaries. So it's an inverted pyramid with the skull base superiorly. So if we see, it's an inverted pyramidal shaped structure with the base, that is the superiorly base is the skull base, the hyoid bone is inferiorly, which is at the apex, and it is bounded posteriorly by prevertebral fascia, laterally by different structures like mandible, medial pterygoid, deep lobe of parotid, and medially the buccopharyngeal fascia overlying the constrictors are present. So medially it is formed by the buccopharyngeal fascia overlying the pharyngeal constrictors. Now this parapharyngeal space, you can divide it into two compartments. One is pre-styloid compartment, another is post-styloid compartment. So don't worry, it's very easy. Just you have to note down the components. So just know that in pre-styloid compartment, and one more thing is these compartments are formed by a division by a plane, that is the facial condensation from the styloid process to the tensor valley palatini. So a facial condensation, it passes from the styloid process to the tensor valley palatini and divides this pyramidal space into two parts. One is pre-styloid, another is post-styloid. So pre-styloid have maxillary artery, fat, deep lobe of parotid, and lymph node. Your post-styloid have very important and vital structures like carotid artery, IJV, cranial nerve 9, 10, 11, sympathetic nodes, and lymph node. Now, very important part is the management, on which you have most chances of question being asked. So if your patient is clinically stable, if they mention it in the question, then we would prefer the conservative management over any surgical treatment. So a stable patient with a small abscess, no evidence of complication, you can give medical treatment with IV antibiotic. And it is important that the antibiotic that you choose should cover the gram positive cocci and anaerobe. Why? Because the most common identified aerobe are group A streptococci, fusobacterium, haemophilus influenzae, and the most common anaerobe is staphylococcus, means basically the peptostreptococcus, you can say. Now, if the patient is not responding to the medical management or IV antibiotic, then what you can do is you can have a surgical incision and drain that pus. So surgery is also considered if the medical treatment fails, or if there is any complication or the collection is very large, then straightforward we can move to surgical treatment. So one of the approaches, trans-cervical approach, where what you do is you give a transverse incision at the level of greater connu of hyoid, about 2 finger breadth below the angle of mandible, and you drain this parapharyngeal abscess, right? So this is a very important question that you should know, and the second question will discuss it in the another part of the clinical short series. So you can also get these clinical shots via the Medex app. The link will be provided below, and you can WhatsApp me your number on 8840804798. So you can, by WhatsApp, you will be getting important updates, and you will be in touch with me so that I can better be able to guide you. This is Dr. Shivam, hoping that you all stay safe and keep working hard so that you achieve whatever you are working for. Stay happy and stay cool.